Really appreciate you taking your time out of your day to join our webinar. I am Mike Cumbo. I'm a member of Anderson ZurMuehlen's Healthcare Specialty Team. I'm really excited that you guys are on the call today. And a lot of the information presented is going to be relevant to all businesses, but the focus today is on healthcare providers. So much of what is said today will specifically pertain to them. As we're going through the presentation, if you have any questions, please submit them through the chat box at the bottom of your screen. And if time permitting at the end, hopefully Julie and Rick can answer those questions. I am really excited to introduce Rick and Julie from the Rybar Group, Rick Reed and Julie Hardy. The Rybar Group is a healthcare consulting firm that works with healthcare providers on a national basis. They specialize a lot in management and compliance issues. They've been a great resource for Anderson ZurMuehlen and provided us with a lot of support. And we met Rick and Julie through the BDO Alliance, which is a network of CPA firms that are aligned with the accounting firm BDO. BDO is the 5th largest accounting firm in the world, and the Rybar Group does consulting with them on a regular basis and with their clients. We've had the privilege of seeing them successfully help clients with revenue maximization. They have a great provider payment analytic tool, and they can offer a lot of help in making sure you're billing and coding correctly so you're maximizing every dollar that you deserve. And with that, I'll turn it over to Rick and Julie.
Hi, everybody. Thank you for allowing us kind of into your living room, offices, dining room, kind of wherever you happen to be. I wanted to kind of our objectives for today. I've got to just close this box because I can't see it. Whoa, that's not what I meant to do. Our objectives of today are to discuss the various relief programs that are available, the Accelerated and Advanced Payment Program, the Paycheck Protection Program, the CARES Act, a little bit on FEMA grants, and some special payments that are applicable to rural healthcare providers. Learn a little bit about some unique billing rules, learn about telehealth billing and some of the grant programs. And then more importantly, what do you do now to support the COVID-19 related expenses and revenue losses that you've experienced, and the importance of having some cash reserves. So some payment relief programs. I wanted to talk about, and first of all, as a disclaimer, most of the information in our presentation today was updated as of yesterday. Some of it was updated as of this morning, and a couple things I just got an email on earlier this afternoon that we can talk about. So all of these programs are very, very fluid and change quite rapidly. So next slide, please. Just real briefly on the accelerated payment programs, this was really a loan program, so it has to be paid back. The biggest thing about this program is it's currently has been suspended because of the other payment relief programs that are available. But if you did get a payment under the accelerated program, if you could advance it, please. One of them they did for providers, they've processed over 21,000 applications and gave, and I listed all the zeros on here just to get a gravity of the money involved. They paid out $59,600,000,000 to providers and physicians and other Part B providers. The government's paid out $40,400,000,000. Next slide, please. Thanks. So the recoupment of this, they're going to start withholding 100% of your payment after 120 days after issuance of the payment. Hospitals and critical access hospitals, PPS hospitals and critical access hospitals have a year to pay this back. Everybody else has 210 days to pay it back interest-free. The unpaid balances will be charged, I think as of today, it's about 9.6%. That's percentage is set by the Treasury Department. And for those cost reporting folks on the on the presentation today, that is a non-reimbursable cost. That interest is a non-reimbursable cost on your cost report. So the Paycheck Protection Program, this actually, I had quite a few updates today based on the information that came out yesterday. This is, the Paycheck Protection Program is a loan program that has a forgiveness provision. It's the intent of Congress to get the money into the hands of the United States citizens who have been furloughed or who would have been furloughed due to the various states' mandatory stay-at-home executive orders. The criteria, one of the criteria for this is that you have a company with fewer than 500 employees, and that's defined as a head count. It's not an FTE in this provision, and we'll talk about the FTE portion a little bit later. You have to be impacted by COVID-19. You receive a loan, and that loan is calculated based on 2.5 times your monthly payroll average. It can be used for payroll, mortgage interest, not principal, but just the interest, rent, utilities, and employee health insurance. It cannot be used to pay the employer's share of FICA tax. Again, the calculations are based on your 2019 payroll. It can be forgiven, and this is kind of a technical part of this, of the rules, is this the loan can be forgiven if the current employee levels are brought back to where they were at the end of an 8-week period. And this is really to cover 4 2-week payroll periods. And you have to use 75% of the money to cover those payroll-related costs. Excuse me. And there's an attestation required with documentation. A lot of folks are really worried right now about the attestation and complying with everything that is required for this program. But again, this program was really intended, like the point 1 says, is to get money in the hands of those people so they didn't lay off for those employers, so they didn't lay off their employees. So, and we're going to talk about this in a moment. You have to have good documentation to support the use of this money, but there is no reason why as long as you're using it for its intended purposes, that you can apply for this loan, keep the money that you already have, as long as you have good documentation, and not to be scared off by the fact that there's an audit provision and they're pretty tough and there's penalties, but a lot of it is all about the documentation that you have to support the need for the loan and what you use the money for. A couple of the other things is it doesn't cover employees that make over $100,000 a year. You can't use it for that. And the Small Business Administration will audit every loan over $2 million. That does not say that they won't audit loans under $2 million. So if they think they need to audit it and they think it's appropriate, they will do that. And the reference for that is in the Q&A that was published just yesterday. It's question number 39. This was really, the funding was established in 2 different time periods. There was the first round was April 3rd to April 16th, and they granted they granted 1,661 loans for $342 billion. It's just amazing how much money is involved in all these relief programs. I was on the phone with a client the other day, and we were talking that there's 1.1 trillion, and it's based on a calculation of $246 trillion. And we kind of laughed that this was a small rural hospital, that the CFO and I would ever be talking about trillions of dollars. But there is just a lot of money involved in these programs right now. So they ran out of money from the first program. So Congress passed a second round of the loans that went from April 27th to May 1st. They guaranteed 2.2 million loans for another $175 billion. And when everybody was applying for the loan and the banks were going through, the SBA portal actually crashed. And there was, they had a voluntary repayment option in case you didn't qualify for the loan, that you could repay the money with no questions asked. That actually originally expired today. That safe harbor was extended for a week, and it now expires on May 14th. Next slide, please. Thanks. The eligible expenses for the payment protection program are salaries, wages, commissions, or any other similar compensation that's cash that's gone out to your employees, including a household stipend or an allowance. It's payments made on vacation, parental leave, medical leave, sick leave, holidays. There is, it includes, group health insurance payments, retirement payments. It includes state and local payroll taxes. That's the employee deduction of those. So it's really kind of based on the gross payroll. And you can also use it to pay, like I said before, mortgage interest on obligations that were in place before February 15th of this year. Leasing, that if you've leased a building or an office or any equipment, it can be used for the interest for that, and it can be used for utilities. Next slide, please. Some ineligible expenses is it can't be used to pay an independent contractor. It can't be used to pay compensation in excess of an employee who makes more than $100,000 a year. It cannot be used to pay the employer's share of payroll taxes or FICA. It also can't be used to pay for qualified sick leave where there's another credit available that paid those sick leaves. And it can't be used in unemployment cost, is not considered a payroll related cost. But the biggest thing too about, if we can go back just for a sec. Thanks. So on the cash compensation to people paid in excess of $100,000, a lot of this is really kind of based on your documentation and your comfort level with that. So if you have an employee who makes over $100,000, when you calculate kind of what you're going to use the money for, it's best just to exclude them and make it obvious that you're excluding them. So your documentation will show that you're complying with really the letter of the law and the intent of the law. Okay. The loan forgiveness portion, you have to use 75% of the money to pay those allowable payroll related costs. Again, you can't use it to, that should say, I'm sorry, I thought I caught this before. You can't include the employer's share of, you can't include the employee share of FICA if you're deferring that FICA payment. So you've actually got to pay the money out. Again, it's really important that you build your documentation as you go and as you spend the money. Build that documentation now during the emergency period. Don't think you're going to go back and do it later and remember everything, but just keep track of it now. Again, that the loan forgiveness periods is 8 weeks starting from the day you get the funding. So in order to be eligible for the loan, you had to have 500 or less than 500 employees. That was based on a head count. The count for forgiveness is based on an FTE or a full-time equivalent. So if another thing, if you laid off an employee and then you offered them their job back at the same amount of hours and the same pay, and the employee declined that, that's not considered a reduction in your FTEs for the loan forgiveness, as long as you have documentation that, again, you offered them the same amount of money, the same amount of hours, and that they declined. So the best evidence that you can get for that is have that all in writing and have the employee actually send you in writing or in email some type of written communication that they declined your job offer. Then it doesn't count as a reduction in FTEs. Again, you guys have a copy of the slides, so I don't want to take a lot of time kind of going through some of the math, how this works. But so another thing, an important thing is when you start out in the period with how many FTEs you end up with, you start with, just kind of as a rule of thumb, if you start with 200 FTEs at the beginning, you ended up with 200 at the end. The other thing that's important, the third point here, is the reduction in the total number of FTEs or reductions in salary, because that can also affect your forgiveness, that occur between February 15th and April 26th. You have until June 30th to restore the FTE levels or those salaries back to their original level, and then that won't impact your loan forgiveness. So again, how you can not lose a portion of your loan forgiveness is rehire the employees, and again, have good documentation to support that. And if someone reduces their salary, who is kind of under that $100,000 mark, put their salaries back to where they were before. If the loan or a part of the loan is not forgiven, the remaining portion converts to a 2-year loan with a 1% interest rate. You can pay the loan off early, during that 8-week period, and then there's not a penalty. And the first payment is not due for 6 months after the 8-month period, after the 8-week period. Again, documentation is really the key, and we're going to go through this a lot. So this probably would have been a good game to play on how many times I use the word documentation. But documentation is the key to support the loan forgiveness and the use of the money. Again, organizations should be able to support that they had a cause, that they needed the money for COVID-19. And if you think about it, it's not just what's going to happen during the emergency period. There's going to be a lot of things that linger on for a long period of time, especially in a lot of healthcare organizations. And our group spends 100% of our time in the healthcare space. So there's going to be a lot of people who aren't going to be, if you're physician offices, there's going to be a lot of people who aren't comfortable coming to the doctor's office even after the emergency period. If you're a hospital, there's going to be people who aren't comfortable coming to a hospital and aren't kind of willing to, quote unquote, take the risk of being exposed. So the impact of COVID-19 is going to last longer than just on the emergency period. If the emergency period ended tomorrow, the world's not going to be back to, quote unquote, normal, the next day. It's going to take a while. And part of that is the impact of that. So as you're building your support of why you need that loan, remember the need of the loan was so you could continue in your operations. So you didn't have to lay off people because you needed that funding to support the payroll during your lower times of not having any business because of the stay-at-home order. Because of for a lot of healthcare settings, all of the unnecessary procedures that were delayed, that caused a hardship on folks. It was intended for that reason. So make sure you can just build your supporting documentation to show that there was a reason that you applied for the loan, and you used it for for 75% of the money was used for payroll, and what other things were used for, those allowable costs. You need to keep your records with the assumption that you will be audited by the Small Business Administration. Err on the side of caution. I was an auditor for a long time and was a Medicare auditor for a while. An auditor will never tell you, wow, you kept too much documentation. The more documentation, the better. For things that we help our clients with, we really try to build those documentation programs so you're providing everything the auditor needs to look, you're answering all their questions, and you're going to be able to take it. You're going to be able to provide them everything they need so they don't have to look anywhere else. So again, err on the side of caution and provide as much information as you can. Maintain support how you use the money. Some folks are setting up a separate bank account. I don't think you need to do that. But you need to have good records to show how you spent the money. Again, prepare your supporting documentation during the loan period and document, document, document. So the CARES Act, there was $100 billion in the original CARES Act that was dedicated to healthcare. The first $30 billion was distributed in early April, actually on April 10th, to providers based on providers and physician groups and everybody who billed Medicare during 2019 got a check for or got a payment from HHS, and this was based on their traditional Medicare payments in 2018. There was a second payment that was distributed in late April based on the total net revenue from 2018. The government got a lot of complaints that the money wasn't distributed fairly because it was based on that traditional Medicare payment. So if you lived in an area that had a high volume of Medicare HMOs, then your payment was cut down for that, and so the money wasn't distributed quote unquote fairly. So that second payment went through and they calculated it based on your total net revenue from 2018. So some providers received 2 payments, some providers only received 1 payment. A lot of providers who only received the 1 payment, it was because the first payment was higher than what that second payment would have been based on the 2018 net revenue. Now, the one thing that just came out today was the terms and conditions to keep the money, and we'll talk about those terms and conditions in a moment. But the deadline on the attestation for that terms of condition was going to be May 9th. There was an extension that just came through. I got an email about an hour and a half ago that said that was extended to May 24th. So providers had 45 days from the receipt of the payment to accept those terms and conditions. So that accepting of those terms and conditions was extended. Next slide, please. So kind of a summary of the first terms and conditions. You had to certify that that you billed Medicare in 2019 and you provided diagnosis and testing related to individuals with COVID-19 or possible cases of COVID-19 after January 31st, 2020. And January, that's a special date because that is the day the Secretary declared that there was a state of emergency, was January 31st, 2020. You also have to attest to the fact that you were not terminated from participating with Medicare or Medicaid or any other federal health care program, and that you're going to use the payment to prevent, prepare, and respond to COVID-19, and will only reimburse healthcare related expenses or lost revenues that were attributed to COVID-19. Funds that, So another really an important part of your documentation, the funds can only be made for payment for excess expenses or losses that were not reimbursed by another source. So when you're calculating, and I'm getting a little bit ahead of myself, but when you're calculating your COVID-19 related cost and you received a payment for your payroll cost through the payment protection program, you can't include those payroll related expenses in your losses that were reimbursed by that other program. So your documentation has to be really crystal clear that you're not double counting the reimbursement for those expenses. Because if you double count those expenses, the government has another word that starts with an F for that, but you got to be really careful that you're not double counting when you're calculating your additional expenses and your lost reimbursement, that you're not double counting and getting paid by more than one federal related program for those monies. Next slide, please. So the reporting requirements, you must, in the terms and condition, it's stated that you must submit reports as the Secretary of Health and Human Services determines that they need to ensure compliance. And you have to submit these within 10 days at the end of each calendar quarter for anybody who receives more than $150,000 from the Relief Acts. You have to maintain appropriate records and cost determination in compliance with current or future regulations. And that when you treat a COVID-19 patient who is out of network, you only treat them as an in-network patient and don't charge them any out-of-network cost. So the statutory requirements, they have some provisions that prohibit some of the spending of the money. I thought some of these were interesting. You can't use the money to pay compensation anybody in executive level that is in excess of executive level 2 salary amounts. For 2020, that's anybody who made more than $197,300. You can't spend the money to promote gun control, lobbying, abortions or embryo research, promote the legalization of controlled substances, and kind of the list goes on. You can read those at your leisure, but there are some restrictions for that. Next slide, please. So the attestation is you have to attest to the government that you have COVID-19 related expenses and lost revenues. Your out-of-network patients were charged at in-network rates. You also need to provide documentation to support those, and unsupported related expenses and lost revenues will have to be refunded to the government, and we'll talk a little bit more about those later. There was a second terms and conditions that were issued on April 30th. Those were pretty much the same as the first round, with the exception is that it required the providers to submit general revenue data for 2018 to HHS, and a lot of that information came from whatever tax return you happen to file, whether it was a Schedule C on your 1040, on your 1120 if you're a for-profit company, or your 990 if you were a not-for-profit. If you were a governmental facility, you could submit your audited financial statements to show them to document your net revenue. You also had to consent to HHS that they could publicly disclose the payment made to each recipient from the relief funds, and that you acknowledge that those payment disclosures, I'm going to read this because this is exactly the words that was used in the terms and conditions, is that you acknowledge that the payment disclosures may allow others to estimate your gross receipts, or your net revenue actually, and your program net revenue or equivalent information. So somebody could do the math and figure out kind of what your net revenue was. Now, if you are a not-for-profit organization, that information is really already disclosed in your 990 that's publicly available anyway. If you do not agree to the terms and conditions within 30 days of the receipt of this funds, and now it's longer than that because of the extension, you're deemed to accept the terms and condition. And they also say that this is not an all-inclusive list, that you must comply with every relevant statute or regulation as applicable. So they kind of put a little covering in that they're covering themselves, that this is not an all-inclusive list. So some of the FEMA grants, just from a high perspective, is FEMA is the payer of last resort. So you've got to kind of exhaust all your other avenues of reimbursement before you go to FEMA. FEMA programs are reimbursement programs. You have to spend the money in order to get paid. To be eligible, you have to be a not-for-profit, and you must prove that to the State Emergency Management Department. You must have been asked to do that work. So if you were a hospital who built a temporary facility and you weren't asked to do that, then that's not subject to reimbursement. And a lot of this in this emergency state is a little bit easier to kind of meet that criteria. They'll kind of cut you a little bit of slack because there might be a general communication out to providers to do something, so the work that you're asking reimbursement for that was generally asked for by your state or other governmental entity, that if you can just document that there was a general request to, hospitals need to quote unquote expand your bed capacity. So in order to expand your bed capacity, you did, built a temporary, housing for your patients, so that you can use that as documentation for that. You must be legally eligible to do the work, and your facility must be owned or leased by the provider. So if you don't kind of own or lease your physical building, then you're not eligible for this. Again, you need to avoid the duplication for reimbursement. And again, I've said that several times and will continue to say that. That is really important. You also must participate in a state webinar first. There's a set process that FEMA goes through. And this is kind of untested waters for FEMA. They've never had an emergency that affected everybody before. So some of this is a learning curve on their part too. And again, documentation, you cannot document too much. Another thing is really important to remember is that these funds will be audited, and they might be audited 5, 10, 20 years later. In fact, some of Hurricane Katrina's activity that was paid for from a FEMA grant, and that happened in 2004, is just being audited now. So when it's audited, they're not going to care about that, what the emergency state was kind of in the middle of it, because you're not going to be in the middle of it when you get audited. So make sure you build good documentation now for that. Some of the special payments for rural providers, there's $10 billion of special rural payments that are available. The applicable providers, you have to be you can be a critical access hospital, a rural health clinic, a rural PPS hospital, or a rural community health center. And this payment is based on your fiscal year 2018 operating expenses. And I believe Medicare or HHS published the criteria, the calculations, criteria of how they calculated the amounts yesterday. I did not update the presentation for those calculations, but those calculations came out yesterday. Next slide, please. Again, every facility was going to receive a minimum base payment plus a percentage. The funds were going to be automatically distributed on or around May 6th. Each rural health clinic was going to receive a minimum $100,000 with an average of $162,000. Each critical access hospital was going to receive a minimum of $1 million with the average of just over $4 million. And again, there's no requirement of that hospital to be, or rural health clinic to be independent of another system. And in Montana, there were 121 eligible rural providers for a total amount that was going to be distributed of $199,485,740. So when the government did this early in the week, they obviously had already done those calculations, since that's a pretty specific amount. Next slide, please. All right, Julie, I'll turn it over to you.
Thank you. All right, so I'm going to talk a little bit about some of the telehealth changes that were made as part of a variety of waivers set forth, and others are set through interim final rules. So to date, 2 interim final rules have been released from CMS that detail significant changes to both the provision of telehealth services and the billing and reimbursement. So what I'm going to cover today on these lists are not exhaustive lists, but just some of the highlights. So one of the most important things that happened was that the originating and distant site requirements have been waived. And this is pretty significant because telehealth was more of a challenge prior to this PHE or public health emergency, because the patient had to be in a rural location or under a specific type of care like end-stage renal disease, and it was hard to meet those requirements. But where we're at now, essentially, is that a patient or a provider can essentially be located in any physical location in any geographic region. So this opens up a vast area or arena for these services to be provided in a safe and effective manner during the public health emergency. So with this, providers may waive coinsurance and deductibles for the duration of the public health emergency. Ordinarily, this could implicate the federal anti-kickback statute, the civil monetary penalty rule, and exclusion laws, but the OIG has issued guidance stating it will not subject practitioners to sanctions for arrangements made during the COVID-19 public health emergency. Many services that are deemed to be telehealth generally have a restriction that they may only be provided to telehealth patients, or I'm sorry, to established patients. So telehealth services may now be provided to both new and established patients, again, for the duration of the PHE. Again, this gives our providers a vast range to be able to provide services that need to be provided to specific patients. Now, in the interim final rules that have come from CMS, codes for telephone services have been around for years, I think since 2008, but were not previously reimbursable. So in April, they announced that these time-based services would be reimbursed between $14 and $40. Again, keep in mind, these prices were actually set back in 2008 and no one has touched them since then. But last week, CMS revised their policy stating they would be paid at parity with office visit levels. If you're familiar with the E&M codes, they're levels 2 through 4, and both for physicians and APPs. There's also another code set for telephone services provided by a qualified non-physician. However, those codes have not yet received an increase. Something else that has changed is the supervision requirements. So services that require direct supervision typically require that the supervising provider is immediately available in the office suite, but not necessarily in the same room. So now providers can provide that direct supervision through the use of two-way audio and video communication. And now in talking about billing for telehealth, in order to receive appropriate payment for these services, Place of Service 2 was the guidance initially back in March and early April. Bill with Place of Service 2 because that's the place of service for telehealth, but that actually pays at a lower facility rate. So CMS later came out and said use modifier 95, which is going to pay the higher professional fee. And keep in mind, in general, there's not a hospital fee or a facility fee for telehealth services. There never was before last week. And now CMS has published guidance that telehealth may be billed on a UB when a hospital is providing the equipment and staff to support a provider billing a telehealth service. I believe G0463 is the code to be used, though Medicare hasn't actually published any guidance around this. But this is a pretty significant update, especially for our providers who contract with physicians who are providing telehealth services, because in those cases, up until last week, the hospitals were getting no reimbursement, even though their equipment and staff was being used for these services. So I did mention that direct supervision may be provided remotely, but teaching physician supervision may also be provided remotely. It doesn't need to be one-on-one. It can all be provided through two-way audio and visual communication. The primary care exception rule, which applies in obviously primary care clinics, that no longer applies to those lower level E&Ms. It used to be levels 1 through 3. It is levels 1 through 5 now, so even the highest acuity patients may now be billed without the teaching physician present. And some other services may be provided under the primary care exception, such as telephone services. E&M levels for outpatient visits, so 99201 to 99215, those can now follow those much anticipated 2021 E&M guidelines. So this means that instead of documenting those lengthy notes that our providers are documenting in the clinics now to cover all of the history, exam, and medical decision-making components, they can base their code just on medical decision-making or time. And the time doesn't necessarily have to be spent counseling or coordinating care like it used to be. It could just be that if the visit takes more time than it typically would, document that time and you can bill a higher level. Another change, and this is mostly related to COVID testing. Advanced practice providers may now order, furnish, and supervise diagnostic tests if allowed by their state scope of practice regulations. So I'm going to cover some of the declaration waivers pretty quickly. I see that we've only got about 15 minutes left, and most of the information is up here on the screen for you. But CMS is allowing patient screening off-site from the hospital campus now. I think everyone has seen a lot of these with the drive-through testing centers, things of that sort. Hospitals without walls falls under this. And physicians whose privileges expire, they can actually keep going until the end of the PHE emergency without having to renew their privileges right now, without full medical staff review. And then there's housing acute care patients in IRF or IPF. This is kind of across the board. They're saying an acute patient can be housed basically in any type of setting. So this waiver specifically applies to IRF and IPF, but what they're saying is perhaps you have maybe a partial hospital program, but you're all out of acute care beds. You can move your patient to that partial hospital setting and still bill for the acute care service. This is kind of continuing what I just said here for the inpatient rehabs and patients in the acute care unit of a hospital, inpatient psych in the acute care unit of a hospital. Again, these patients don't necessarily have to be in that defined specified unit in order to receive the appropriate payment for the level of care that's being provided. CMS is waiving the requirement for a 3-day prior hospitalization for a SNF stay. For those who are affected by COVID-19. And they're also providing relief to SNFs on the timeframe requirements for the MDS assessments and transmission. And then for hospice, the requirement to use volunteers is waived, anticipating the volunteer availability. And use will be reduced related to COVID-19 surge and potential quarantine. And hospice facilities are not required to provide certain non-hospice services during this time. And then practitioner locations. So they're temporarily waiving the requirements of out-of-state practitioners to be licensed in the state where the patient is located. So again, thinking about telehealth, the originating site is where the patient is located. And it used to be that if your provider was in North Carolina, but the patient was in Michigan, the North Carolina provider had to have, they had to be licensed in the state of Michigan, but they no longer have to, so long as it's not violating a state law. And the Federal Communications Commission grant, they have provided some additional funding for providers to purchase and implement services and technology to provide telehealth services. So on this slide, I have a list of eligible facilities that can apply for the loans. It covers a wide variety. But essentially what we have found that this misses is independent physician practices aren't covered under this. But aside from that, most providers are. And then some of the eligible services, I have them listed on the slide, but some of the clients that I'm working with now, they are upgrading certain software to make it easier for their providers to provide telehealth services. They're purchasing equipment for their patients to take home that will be monitored remotely. Some of them are actually even considering purchasing equipment to send to a provider who may be in an urban location so they can provide telehealth services to their patients who are in their rural setting. So we can definitely get creative with the type of services that are being purchased. Some other things are if there's, say, like an annual fee to upgrade your EMR, if you pay for it before September 30th of this year, then you can submit to have that reimbursed through the FCC, that annual fee. If you have to upgrade your broadband internet, everything that you pay between March and September of this year, that can be part of the grant. And we're helping our clients complete these forms right now. So if they're a rural client, it's generally a little bit easier because they've completed a lot of the pre-work, because the FCC has previously offered a lot of these telehealth funding opportunities to rural health providers in the past, but not the urban providers. So again, rural providers don't generally have to do as many of the pre-steps as the urban providers do, but completing all of the forms and getting the necessary documentation in place is going to be key to getting the funding, but it's happening pretty quickly. They're dispersing the funds generally within about a week of receiving the application. And this slide is accidentally a duplicate, so we will move on back to Rick.
All right, so when you go to support your lost revenues and expenses, next slide, thanks. Really your justification, again, develop your documentation with the assumption that you will be audited in the future for this money, for the to be able to keep all or a portion of the federal and state funds that are paid out, especially the federal funds. And that's really important. Another thing important to remember about this is a lot of what kind of came out with some of the payment protection loans is they first kind of lead with, falsifying the application to receive this money could result in, fines and imprisonment up to 30 years for bank fraud. I think the government does a lot of that to for lack of a better word, to kind of scare folks into thinking to not applying for this reimbursement. But if you're entitled to it, it's the intent of Congress and the president that you get this money. They've allocated billions and billions and billions of dollars, and they want this to go to help your organization so you can survive and make it through this emergency period and the kind of all the repercussions that are going to follow. So build your documentation with that, and also remember that you're going to be audited by probably the same auditor if you submit a cost report that's going to audit your cost report. So those guys, I used to be one of those guys. Our main rule was, when in doubt, throw it out. So they kind of have that mentality. So when you go through that, think of building it in to be able to have enough supporting documentation during the event so you can kind of get past that and justify kind of keeping all or a portion of this money. Again, avoid duplication. Don't request payment for more than one federal or state program for the same thing. So if you get the payroll protection program and you get money for that payroll for that 8-week time period, don't claim when you calculate your lost expense, that your extra expenses, don't claim payroll expenses for those people that you included in the payroll protection program. Again, don't miss a reporting deadline. That's really important. The easiest thing an auditor can do is to throw something out based on you missed a deadline. So don't miss a deadline. Again, the expenses, document what extra amount was spent. Keep time logs for those people who don't have the payment protection program. Keep time logs of all the time that you have spent and your staff has spent on COVID-19 activities. That includes the extra meetings that you've had, the time you spent with your local and county emergency groups, working out plans, how you're going to provide care, prepare for that surge that has or hasn't occurred, but really keep track of kind of all of those things. The additional pay that you've given out for those people who are working during the emergency period, again, don't duplicate it, but include for that. If you've kept staff on, if you have normally done a good job of kind of flexing your organization based on your volume, and at this time you didn't flex down because you have very little volume because of all those elective procedures have been postponed, figure out how much money you've spent that you normally would have flexed down for to keep that that's a cost of this period. My daughter had an elective procedure yesterday, went to the hospital. I was talking to the nurse about when they started back working, doing elective surgeries. And she goes, "Oh, we've been here the whole time. We've been doing elective procedures. Been kind of boring, but I still kept my job. I still was being paid." And a light bulb went off in my head going, that's a COVID-related cost. You normally wouldn't have a full staff in your surgery department when you have no scheduled surgeries. So keep track of things like that. The extra PPE equipment that you bought. And if you now are going to build, one thing that this has really taught us, we're going to talk about this in just a second too, is during this emergency period, you need to have some supplies on hand. Who would have ever thought this would have happened, where everything kind of, all just occurred across the whole world? You need that PPE equipment. You need those extra supplies. You bought extra supplies. You bought additional drugs for the emergency period. Again, keep very clear records and good supporting documentation. Next slide, please. Again, documentation is the key. Keep your records during the emergency period. Use the payroll system as much as you can. That's the best documentation. On where to keep things in your general ledger, there's really two schools of thought. One is to set up a separate department that you put all of your COVID-19 related costs in. The other is to have unique expense accounts set up in the appropriate department to record those costs. Make sure you work with your vendors on your invoices. If there's COVID-19 related activity that you're being charged for, make sure that's on your invoice. That's external documentation for the auditor. They'll allow that. And again, err on the side of too much documentation. Lost revenue, keep track of the federal and state relief payments that you receive. Keep a log of those payments by program that it has given it. On your revenue losses, you can calculate it a lot of different ways. You can look at the trend. We have clients that were kind of doing a certain amount, and then in March and February, kind of the bottom dropped out. You can keep track of that revenue loss. You can do a year-over-year comparison in case you have a lot of seasonality work. I worked in Florida for a couple of years, so in the winter was always really busy with Medicare. Kind of the bottom would have dropped out with that. This year, support why the revenue dropped. Don't just assume that the auditor is going to know. Show surgery schedules before and after that your elective surgeries dropped out. Your referral logs show that your referrals, you normally get X amount of referrals, you now have a lower amount. Why? And show that. Keep a log of your missed or canceled visits, or days that your offices were closed, and how many of your average visits were during that time period. Another thing that I was thinking of earlier today, if you do, since the auto insurance companies are now giving rebates because nobody's driving, is keep track of it. If you're a facility, if you're a provider that takes care of a lot of auto accident victims, keep track of the, you normally you have 10 auto incidents a month, you now had 1. There's additional lost revenue for that goes into support that revenue drop. Next slide, please. Again, on the audit process, there will be an audit process. And again, it could be years down the road. Like I said before, they're still looking at Hurricane Katrina claims. Keep good records during this emergency period. And, you know, again, like I said before, no auditor has ever said, wow, you kept too much documentation. This is way too complete. So I just wanted to just take real briefly on the, you know, the thought of you need to have additional revenue, additional cash reserves, and a strong balance sheet. You know, the whole bottom dropped out of our economy. Who would have ever thought that would have happened? You know, a lot of times, you know, when bad things happen, they happen regionally, or they happen, you know, in certain cities, certain states, but everybody was affected by this. You know, most providers operate on very thin margins, and those thin margins result in small, if any, cash reserves. You know, how can you improve your cash reserves? I guess the most obvious thing is, you know, decrease your spending. Well, a lot of times that's hard to do, especially in rural organizations. They have a tendency to be a little bit more efficient because those dollars are fewer than their urban counterparts. The other one, you know, increase your revenue. That also is harder to do in a rural area because you have a low availability of patients. Next slide, please. Kind of ways to improve your cash position. You know, filing your cost report to really optimize that reimbursement or getting what you're entitled to get. We are not proposing that you do anything, you know, that will keep you up at night that's not morally, legal, or ethical, but there are different options that you have available. Make sure you take advantage of all of those options. You know, are your costs in the right cost centers? Are your statistics up to date? Are you using, are your cost centers and those statistics reflective of your current operations? Are those statistics giving you really the best results? You know, those approved statistics, are, you know, are those giving you the best results that you can get? For rural health clinics, are your visits correct? Are the providers reporting the FTEs, are those based just on the clinical time, or does that include, you know, their CME time or their vacation time or their committee work at the hospital time? There's also an exception for the productivity limits. Is your coding correct? You know, is your coding correct in, you know, are you charging completely? For rural health clinics, you know, since you're paid an all-inclusive rate for Medicare and Medicaid, a lot of providers don't really care how they charge for those. It's all level 3. I was a CFO of a hospital who had 5,000 visits. There was 2 level 2s and 1 level 4, and everything else was a level 3. So, you know, for that affects, you know, Medicare and Medicaid doesn't matter. All your other payers care. That matters. That affects your reimbursement. You know, is your coding up to date? Are you charging too high or too low? Because especially as a critical access hospital, you can charge too high, and you actually shift that reimbursement to have the patient pay rather than Medicare. And there are a lot of other regulatory reimbursement opportunities that are available that you can use to build your cash position and make your balance sheet stronger to weather these storms. And that is kind of it of our formal presentation, and we went a little bit over.
I see in the chat that someone said we will answer questions in a follow-up email.
Yeah, thanks, Anu. We've got a copy of all the questions. We'll send out an email with an answer to each one of the questions so everybody gets the answers, just because we are out of time now. Appreciate everybody spending your time. Hopefully you got a lot out of this and picked a few things up. I hope everybody has a great rest of the day. Thank you.